everyone. Welcome to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the host for the Dean's Chat podcast. As always, I'm joined by my co-host, Dr. Johanna Richey. Hello, Jo.
Hey, Jeff.
How's your weekend?
Oh, it was wonderful. Mother's Day is special.
Oh, it is special, no doubt. Well, we have a phenomenal guest today from Chicago, Dr. Edgardo Rodriguez. Dr. Rodriguez, welcome to Dean's Chat.
Fantastic. Thank you for having me. Great to see you.
It's great to see you. You know, we're kind of informal on Dean's Chat, so if it's okay with you, let's go with first names, Edgardo, Joe, and Jeff.
Excellent for me.
All right. Well, I was going to start with a little bio to kind of kick us off. You've got a lot of things on your CV that we want to talk with you about today. But the first thing I wanted to mention is you are the director of the Chicago Foot and Ankle Deformity Correction Center. You're also the fellowship director of the Deformity Correction and Limb Reconstruction Fellowship Program, which, by the way, is approved by the Council on Podiatric Medical Education, which we'll talk about. You are also the associate director of the Ascension Health St. Joseph Hospital Podiatric Surgical Program. And we were just talking before we went live that you're a busy guy.
Yeah, well, education is one of my passions. So at this point of my career, I want to say I would like to summarize in some way my experience and pass this experience to as many people I can.
Okay.
And I see that this generation of residents and students, they're in a different wavelength than us. So the pandemic kind of set the radio completely different. So I think that prior to the pandemic, most of us we were in FM stereo, the station. But now we have FM, AM, satellite stereo, and it's education for us as educators. It has to be done in a different fashion. And I think that the sooner our generation comes in peace with it, the less frustrating it's going to be for us to deliver the message.
Well, Joe and I can relate to that, Edgardo. I mean, we've gone through tremendous sea changes in education at the college level. Maybe one of the first things we can talk about is your fellowship program. That is just a hot topic in podiatric medicine. Fellowships are becoming more prevalent. We have every year we're graduating 550 residents or so into the workforce, and they're not quite sure what to do. Should they take the job offer? Should they apply for fellowships? We'd love to talk about your fellowship program. Just a side note, Stephanie Oxman was sharing with me her experience in working with you, and she said it was just phenomenal.
Yeah, so I think that fellowship these days, I see it like everybody's getting the cake, but fellowship is like the icing on the cake. And from the prior fellows, what I'm seeing is that it's getting easier for the fellowship-trained podiatric surgeons to obtain academic positions in hospitals that are like teaching hospitals. They do like this fellowship concept of additional training, additional emphasis in something specific, and target treatments. So then in that way, they could perhaps, in this academic teaching environment, they can develop or carve out different services. So I see this as a trend. Our training these days, as you know, is way different than when I came out of training in 96. It's 7 years of training. And I think that we were discussing this, from what I think, it's about 60% of the graduates residents that they would love to be in a fellowship position, but there's not that many. So I think that between the CPME approved fellowship and the ACFAS, we cannot accommodate everyone. So they're becoming extremely competitive, as you know. And I truly believe that if someone has the ability, the circumstances are right, to put an additional year and be unique in whatever circumstance or environment, I'm a big proponent. 1 year is another year of training, another year of sacrifice, but we know that the good things come with an effort. Good things come with a high level of discipline. And our field is in healthcare, is medicine and surgery of the lower extremity. And it requires a lot of discipline to be successful.
Right. Joe, you graduated from the Midwestern University, Arizona College of Podiatric Medicine back in 2009, and you didn't have fellowship options like we have today back then, did you?
No, and actually, I was interested in fellowship and was kind of talked out of it by my attendings at the time. Now, in fairness, later to come find out, they were trying to find a position for me to stay on as faculty. So maybe there was some bias behind that, but maybe there wasn't. So yeah, I think the discussion around fellowship has shifted and changed significantly. And I think it's a wonderful opportunity. I think the keys are knowing what the fellowship can provide. And I think some of that is harder right now for applicants to get all of that information. I think CPME and ACFAS are doing a lot of good to kind of help bring more awareness and attention and help applicants, residents find quality programs, not just something that's a fellowship because someone's calling it a fellowship, but really good opportunities to enhance and improve or just get the confidence in their training.
Yeah, as you guys know, our anatomical region of treatment continue expanding. We're not just anymore dealing with foot pathology, fractures, and things like that. We are really practicing soft tissue of the lower extremity, nerve repairs of the lower extremity, bone defects on the tibia, so things are just more complicated because patients are in need of these procedures. I mean, it's the training only comes because there's a need for this expertise and skill set. So, and it benefits our podiatric residents. It benefits our patients because they're gonna have better fit physician treating them. So I think it's a win-win on that in that sense. Yes, I mean, in my time, there was not really such a thing about fellowships either, but training is different these days. And I think that if we can achieve the highest excellence within 8 years of training, dealing with the lower extremity, I think long-term, we're going to make a better impact in healthcare in the allopathic world.
And just to piggyback off that too, some of the other, like the work hour restrictions are different than they were when I was a resident. They were starting to pilot some of that in terms of 120 hours, I think. And we had to start logging just to see if our program would be able to qualify. And there were some pretty significant changes that had to be made to meet that. So, and not that that's a bad thing. I think we had talked a little bit of this younger generation has a better vision about their life and their alignment of their values with what they want in their work. But at some point, if you're going to shorten the amount of time a resident's allowed to be in a hospital, which is appropriate, 120 hours a week is a lot.
Yeah.
You do take something away, though, if the next day they have to be off and that's the day that there's all these great cases. So I think there's a give and take there. And I think we're still figuring these things out. And then to your point, even more opportunities. I mean, bone transport, some of these things were being done, but when I was a resident, but not to the degree and the opportunities that now more people have become experienced in. And actually, I would love to ask you you're the founder and past president of the American Microsurgical Orthoplastic Society. And so microsurgery, again, in terms of one area of just the soft tissue management, if you could talk a little bit about that.
Yeah, so the long time ago I was very blessed to the sense that when I was in 96, I was able to obtain a fellowship program at that time, and that was in Chicago with Dr. Fred Rahimi. And as part of that fellowship, I was able to rotate with plastics. And in plastics, I clicked with the department very well, and immediately they invite me to go into medical missions. And when I went to medical missions with them, I didn't have not a single dollar I could just, spare. So I remember telling the plastic attendant, said, listen, if you take care of my flight and my food, I'd be there. Other than that, I cannot make it. I don't have the income to do it. And they took me along, and I did all type of plastic procedures, and I got click. I said, okay, I need to figure out a way in which I can merge plastics to the lower extremity, learn some of these soft tissue reconstructive procedures. And then in one of the trips, there was a child that had a bilateral congenital deformity, clubfoot type, and the multiple procedures that were done on that child, things were not going well, 7 years old. And they were even thinking about doing transfigural amputation on the child. So, but then one of the plastic surgeons said, hey, there's an individual that is coming from Dallas, Texas, the Baylor, that he trained in Russia on how to put the leg straight with this device around the leg. And I said, well, I guess I need to stay here and see what they're talking about. And I saw the device, what we know is called an external fixator around this child, both limbs. And then in another trip that I visited the same city in Honduras, I bumped into one of the nurses that was in that medical mission group. And I say, hey, what happened with that child that has this device around? I mean, I didn't know the terminology. And she said, Doug, that child is riding a bike. And I'm like, I knew I had to find a way to be able to offer that. So being able to see what could possibly was the future for me at such an early time in my career was very touching. It was very insightful in the sense that I knew immediately that there was going to be a lot of obstacles in the process, but it was so clear for me where I had to go that it was not so painful, the process. I really enjoyed the failures. And in that sense, I traveled to Italy, Russia, did some training in southern parts of France also. And so I encourage everyone to expand their training and to get out of their comfort. And if you're outside of that comfort, you continue growing. So I told my residents all the time, my job is to make you so uncomfortable, but in a good way, because I don't want you to fumble and buckle up. But if I make you uncomfortably, you're going to grow as a physician. You're going to find ways, and you're going to develop this resilience that is so needed these days. Mm-hmm. The pandemic, it really set everything up differently. The way I train now is, I would say it has a higher level of gentle touch. It has a level of more, let's sit down and see where you struggle. If I see that you're not doing that well. So it have opened up a different way of communication, which some of my colleagues cannot adapt to it. I encourage everyone that is listening to have more patience because it's a different story. And if they cannot develop the skill for patience, let's put it that way, which is a skill, I think that they should move up. They should move out of the way and don't be in contact with students and residents anymore. You're going to be passing all that frustration to them, and it's not good.
That's profound. That's a game changer for you, wasn't it?
It was. I think I learned so much from the pandemic because I suffered a lot. I was isolated for a long time. And I think that, we didn't learn anything. We're such a bunch of morons, isn't it? So I think that we need to learn. And if we cannot learn from a pandemic, my God, it's terrible. So I think our residents, they learn a different way how to learn. So now we need to learn how they learn. And it's a different story. It's a different entity, let's put it that way. And that's all at the school levels also, because I see the students all the time, and you want to in some way make them realize, but that interest has to be developed in a different way. And I'm not sure if sometimes we can deliver that message adequately.
I think it's a work in progress. I knew that we had a different animal on our hands during the pandemic when one of the classes petitioned to never come back for class. They wanted to do what we're doing right now.
Imagine, so how could you just be a good clinician if you're avoiding human interaction? If you're avoiding seeing that patient. So from the pandemic on, every time I call my dear friends, I do FaceTime so I can see their face. So I change a lot of the way that I even communicate with my close friends. And it's like, only you do this FaceTime. And I said, yes, because I want to see your facial expressions. And so you have to apply it on yourself and your environment. And then perhaps by example, they can follow your lead.
Yeah, I think the pandemic definitely taught us about how important the human part of medicine is. When people get to see this much of you, I make the joke that, there's no Botox in the world that is ever going to fix what the pandemic did for smiling with my eyes. I haven't had Botox yet, but just in terms of the way that you processed how to connect with people when there were so many other barriers there, but that connection was so important. And if nothing else, that was the only thing we could provide people. And we don't want it to get to that point. And I love what you said about with students, like slowing down a little bit and the empathy part, the growth only happens in vulnerability part, like all of that is so valuable. And now I want to come be a fellow at your program because we do communicate differently than this current generation. And I know they sometimes get a lot of flack for not being motivated or, whatever people are kind of spreading out in there. And that really has not been my experience at all. They may have different values. They may have different priorities, maybe, or just different ways of communicating. But that doesn't mean that they're not passionate and engaged and interested. But to your point, it's our job to help them find those ways to connect the dots and do it in a way that makes sense for them. So I love everything that you're saying. And
what can I say? If we can show them what is really essential, which is really kindness.
Yeah.
Is something that sometimes how to play it in a way that you can educate also has their ways. Because I told my residents, I don't use the word nice anymore. I don't think I'm not nice anymore, but I'm kind. Because sadly, nice these days, people take advantage of you. So then I told my residents, I'm kind, I'm going to be fair, but I'm going to be firm. But if I tell you something, it's because I care. If I would not care, I would not be telling you anything. So it's more like a father-son, father-daughter figure in which they need to feel that you have to challenge them. You need to let them realize you're here, but you're not going to do it for them.
Yeah.
So then in that way, they can develop the strength of doing things. That goes all the way also to parenting. You have a child, you do everything for them. They're not going to develop the skills to survive in life. So I think medicine these days, we're living through very difficult times. And I'm part of the medical staff and part of the graduate medical committee. And what is happening in podiatric medicine and surgery is the same that is happening in all services. So I think that we need to make everybody realize that this is a medicine issue. It's not a specialty issue. Everybody's having the same. And I have colleagues in Spain and Latin America, and they're having the same problem with the residents. So this is an international multi-specialty issue because the pandemic changed the entire game. We're living in a society right now that we're not interacting that much. Patient interaction is very limited. Most of the time, you're in front of the computer doing your notes. At the same time, patient satisfaction is not the highest. Services are more expensive. Physician salaries are going, they're less now. So we are playing so many cards simultaneously that is really difficult for doctors to have and feel fulfilled. That's the reason why we have so many physicians going through anxiety, and physician burnout is real. So how could we just overcome all that? That we truly have a passion for what we're doing, and if we can add a little bit of compassion to it, then that could be a true purpose of life. And I'm trying to do the best I can from my end, but we need more people.
I just love your kindness approach as opposed to nice and still high expectations. That resonates. I am sure that resonates with your residents. So how's the feedback been since the pandemic?
Well, let's say, I think it's positive when you see that they feel comfortable to you and they hug you, or they invite you to be with their family. Or I bump into them, like for instance, yesterday I was buying for mothers the Palestinian food in a restaurant outside the city, and I bumped into one of my residents. Immediately he came and hugged me. He said, "Oh, my mom is here. I want her to meet you." And then he took a picture with him. Oh, I'm gonna post it in our chat room. So that's a good indicator that they see me in a way that I'm a leader for them, but I care. I truly care for them. And it's really hard, if you really know that someone cares, how to really go against that person in a negative fashion. So you feel positive, you're supposed to get some positive feedback. So I was trained in a different fashion. It was more the stick and don't question, you do. I knew that I could not do it that way. But the pandemic, it really changed me in a better way as an educator. Yeah.
That's fabulous.
That's how I see it.
Can we shift back to your fellowship for a minute? Because you and I were talking earlier today, and there certainly is a distinction about being approved by the Council on Podiatric Medical Education in terms of goals, objectives, and a curriculum in toto versus an ACFAS approved one. Can you talk about that and why you went the CPME route?
So I do have a great majority of the ACFAS fellowship director. They send to our facility their fellows to be with me. So I know them on a personal level. Fantastic human beings, great intentions, great fellows. And where I stand right now is that the Council of Podiatric Medicine is our highest level of credentialing. It's our residency programs. Yes, it's a lot of paperwork. But that paperwork has a meaning. It has a purpose. And we can complain, or we could possibly do what I do. I just say, okay, it's needed to get a good product. I wish that all the ACFAS fellowship will be CPME approved. That would be best case scenario. Why? Because it's not a college. It's really a council. And then in that way, the fellow is not just limited to that practice perhaps, or that group, but then he has the opportunity to rotate as a fellow in other services in a hospital. And it's great PR for the profession. So like for instance, when my fellows rotates in the plastic department with the orthopedic service, and is helping them elevating flaps or skin grafting or whatever, they look at us in a more partnership, let's say, that, you know what, we need that service close to us because we are problem solver. So but I know that that's not the case, or not possible with all ACFAS fellowship, because they may not have great agreements with the hospital, or the hospital that they work with, they don't have the interest for a fellowship. You have to have that hospital institution have to upfront the first year's salary and benefit. Sometimes they're not going to want to do that. So there's multiple things that would not play all the time. But I wish that all fellowship will be CPME approved.
Now, one of the requirements, if I'm not mistaken, is the fellowship to be CPME approved has to be affiliated with the current residency program.
Not necessary.
Okay.
You could have a CPME approved, and it's easier because a lot of the services are already established, but it doesn't necessarily need to be a tag along on a residency program.
Okay, that makes sense. Wow, that's outstanding. So when your fellows graduate, you can see consistency from year to year with that experience, and then.
Yeah, because they become like a family to me. So, I mean, I have a Dr. Oxman, Dr. Lauren Schnack. She works at the university. Then I have Dr. Katie Ward, that she's with an orthopedic group now in Wisconsin. Then Dr. Siton Chen, that he just was my last one in Jersey. And I'm in contact with them all the time. And then once a year, I bring them all together to what it's a symposium that it's been in place for the last 17 years, that is the Chicago Lower Extremity Surgical Symposium. So I group all the fellows, and I had them attending and visiting and fellows from Latin America and Europe. And we all mingle together for 4 days. So like this year is in October. It's every year in October. We had the pre-course at Texas Scottish Rite Children's Hospital. That is controversies in limb lengthening and reconstruction. And then we have Thursday, Friday, and Saturday cadaveric labs in which we plastic the entire spectrum of limb reconstruction, from tibial defects, bone tumors, amputations, congenital deformities, traumatic events of the foot, and even peripheral nerve and obviously soft tissue issues. So trying to bring some uniqueness to our training and provide a service for additional training for the fellows and other fellows from ACFAS. So it's kind of like give them a little bit more so they can be more unique, and then how to mingle with other specialties, which is essential. I have never had a problem mingling with anyone. I can talk to a fly in the wall, not a problem, but I know that I'm not the norm. So in that sense, I'm very social. Being from the Caribbean, we talk to people. We don't have no problem talking. So I try to encourage communication at all times. And my fellow, in the process of selecting my fellow, I really want someone that likes people, that likes to interact, that is understand that these skills that they're going to learn is to give back. Yes, financially, obviously, it's going to help your practice. But if you can just give me some of your time later on and you can come and be part of our medical missions, it'd be great. So I'm always looking for someone that is going to be trying to give back, someone that is like research, because research is important to deliver the message, to practice evidence-based medicine at all time. It's not really what I used to be trained 20 years ago. It's what is valid today. And yeah, I have colleagues sometimes they say, I've been doing this for the last 25 years. I said, Doc, with all due respect, you've been obsolete for the last 25. So it just, we had to practice that way. We need to educate that way. But it's lovely. I enjoy every bit of it.
One question, Joe, and then I'll turn it over. You had mentioned that you have 60 or 70 applicants for your fellowship position every year.
So there's not that many available. So so what I do is from about 60, 70, it varies a lot because our program, I think we grant interviews to 40 people from 80 some applicants. Wow. So we obtain a lot of people that want to be part of our hospital. And I had to tell you, the type quality of individual is excellent. It's excellent. They have done the reading, they have done the research, and we're looking for that. But back again, it's after the pandemic. we cannot expect that individual with those credentials prior to the pandemic and these days, because you're eliminating then a lot of factors to take in consideration.
That makes sense. Well, thank you. That's just a great overview. Appreciate it.
Yeah, we take from 70. We narrow down to 5 to 10, and then I have my fellows. They conduct the interviews. It's better if they talk to the fellow. I'm always involved in those. We do basically like an academic type of interview, which is basically to see the way that you can solve problems. You may not have the solution, but I want to see how would you like to solve. Sometimes the future fellow may say, well, you know what, doc, I don't know. I need to go and do some research about it. Excellent. Mm-hmm. Or you know what, I will probably talk to one of my prior attending. Great. So the sense of having a plan A, plan B, plan C is part of an orthoplastic surgeon. It's like you go in, you have many options. In orthopedics, it's pretty much one track. But when you become more plastic oriented, you go with multiple options, and that depends on the circumstances. You pull the trigger.
That's great. Joe?
Yeah, no, I'm loving all of this. And, when we just think just basic tenets and basic principles of deformity correction, trauma management, you have two considerations, the soft tissue and the osseous. And you can't only focus on one of them, or you won't be very successful, or you could fail completely. So I love everything that you're talking about. And one of the other things that I thought was really interesting in your CV that you had sent us is it also sounds like you host hospital-based observation preceptorship to surgeons around the country. Can you talk a little bit about that opportunity?
Well, I don't say no to anyone. So it's a problem because then that takes time from my personal life. But I basically, Mondays and Tuesdays, I at least once a month, I allow people to come and be in the lab with me. So sometimes our senior attendings, sometimes our fellow. Or senior attendings, I have a lot of them. There's a significant number of traumatologists from Spain and Latin America that they are in big need of soft tissue training. Mm. Sadly, there's not that much training available. So then I'm trying to do the best I can by publishing data on it, articles and all that. And our symposium, we honor about from 10 to 15 scholarships. So basically, with all the sponsor and support that we obtain, we basically sponsor 10 to 15 surgeons from all over the country to come and learn. So then when they go, they can take care of their patients. And I think that the way that the symposium have been structured is that you listen to some master lectures, then you have 3 days to practice the same skill to be comfortable, and then start. And then there's videos attached to it. Kind of like a mini, concise 3-day fellowship. Mm. It's very intense, but within 2 weeks that I open up the registration, it's full. So I know that there's a need for it. Now, thanks to the Chicago Symposium, then it's going to be close to 8 years ago, Dr. Byron Hutchinson opened the Seattle Lower Extremity Symposium. And just this year, Dr. Guido Laporta opened a similar concept of lower extremity in Jersey. In Philadelphia, he's going to be switching here there. I was not able to be part of that meeting this year. But the concept is to expanding, embracing, encouraging, empowering. So this meeting have a different type of mindset, in which it's a meeting that everybody wants to show their bad cases and we can all learn from it. Instead of just, perhaps I have this great technique, everybody listen to it and execute. So I think it's a different approach. Post-pandemic, we had to be different. I mean, I think it all boils to that.
I think that's great. Sometimes as we've focused a lot, obviously, Jeff and I, in academics at the younger years, early academics, and there's so much emphasis on, inappropriately so, get the best training you can, get a fellowship, get all the training that you can. And then all of a sudden you're out in practice and you're kind of like, well, now what? Like if you start to feel stagnated, or you start to feel, there are certainly courses and excellent courses that are out there that you can participate in, but having an option like this to come with an expert and spend some focused practice. You don't need the, how do you do suturing and how do you do a tendon transfer, but very focused on, let's talk about bone transport or flap, relocate, like those kind of concepts, especially when you have a skill set already that you're wanting to refine or improve. I feel like there are some practitioners that feel a little stagnant and they don't know what to do about it. So I think that's wonderful that this is something that you offer. I think this will be, in my opinion, some of the future of medicine. There's already a lot of surgical coaching that is kind of developing to kind of help people where that conscious incompetence, like I know there are things that I don't know, but I don't know what to do about it or how to improve. So in your experience with this, where you've had residents, you've had fellows, and now you've also had surgeons, are there trends or patterns that you find in terms of consistency amongst all those groups in how you teach or you approach that? Or is it very different depending on the level of your learner?
That's very different, each one, how they learn. But what is really common, the denominator, is that they feel that they need to learn this now and what happened later. Or I need to know this perfect to be able to execute. And my approach is, I'm a forever student. In other words, every day I'm learning something. And if I'm the day before surgery, looking, reading, watching a video that could give me an edge the day of surgery, I tell my residents, perhaps you should be doing the same if after 25 years of training. So the concept is, let the students, the participants, the residents, the fellow, that this is a process of learning. It's a process in which you could fail. It's a process that you can always collaborate, bring someone to the OR to work cases together until you can feel more comfortable. Then you bring someone else, resident, fellow, and that you there's not enough years to learn everything. Simple as that. So we had 3 years plus 4 years. Now it's 8 years. Some with fellowship training, and it's still not gonna be enough. Because every single day there's new techniques, there's new op reports type, there's new changes and modifications of flap. It's overwhelming the amount of information out there. So I had to tell them, I'm a forever student. The minute that I don't feel that I want to be an uncomfortable student, in other words, that could continue growing, I will just quit. I will. I think that's really where I swim and try to be at the same level. That I'm a student. They see me doing dissection like them. They see me how I contact someone else. Hey, come and show me what you were doing. Mm-hmm. That's interesting. And then by everybody seeing that it's more collaboration. Oh yeah, I tried this, but it didn't work out. Well, how many times? Oh, too many. Okay, but then perhaps this. Okay, let's write this up together. So it's surprising to me how in our field that we have to be so embracing, how many people feel very introvert, so shy about expressing themselves. And the pandemic, it just made that worse. The people that were introvert, more introvert. Mm-hmm. The people that were very extrovert like myself, fully depressed because they could not be social with anyone. So it changed everyone. So I hope that helps to answer your question.
Yeah, thank you.
Edgardo, you're explaining like a growth mindset, which is common themes, but were you always this industrious? I mean, how did you find podiatric medicine, or did podiatric medicine find you? And then your mindset throughout the whole process of school and residency and training, and your 25 years of continued learning. It's unique in my mind. I mean, you don't see it all the time.
So I was accepted to medical school also, and I did my bachelor in chemistry, in organic chemistry, and I was not ready to leave college. It was finally my mom and dad said it's time to go. I was having too much fun. It was studying. I really loved being at the university, studying during the day and windsurfing in the afternoon. So I could not just change that life. So college took me almost 7 years because I started on the pre-med. Then I went into biology. I was quite not ready what to do. Then I switched to chemistry, finishing chemistry. And even when I was in chemistry, I was not really like, I don't know what. And I did an additional 2 years in engineering. And I said, okay, my dad said, enough is enough. You cannot continue living with us this way, on and on. No, we cannot continue. And basically, that's when I said, okay, I'm going to apply I knew it was medicine. So I applied to medical school. I was accepted at Tulane program in Louisiana. And then I applied. Then in the process, I started shadowing. And I strongly encourage all the pre-podiatric students to shadow. So I shadow a pediatrician. And even though I love children, the crying and the vaccination and the coughing and the hysteria and you treating the child and the mother, I cannot do it. Then I wrote it with radiology, being in a dark room, isolated, not for me. Then I wrote it with OB-GYN, and that was not really for me either. It was like very stressful, just waiting for the delivery and the running around. It's extremely stressful. Then I scrub in with the general surgeon, and I like the feel of being in the OR, the scrubbing and being sterile, and then doing rounds and in the morning and all this stuff. Then I rotate with orthopedic, and I enjoy the fracture and all this stuff. Then I rotate with a podiatric surgeon in town that he had in one room a child that was not walking right. Then had in another a patient with diabetes with a wound that could not close. Then a fracture because they failed playing soccer. And when I saw that diversity of treatment option, I said, this is me. This is what I like. So that's the reason why shadowing is so important, because then you know that even if it's going to be painful, stressful, you know that you're going to be happy because you're going to be doing what you're looking for. But right now, when I see how we're trying to recruit more students to our schools, we cannot look for interest. We need to spark curiosity, because that curiosity is everything. No one starts running. They start, basically first 2 steps, but no one starts, full cross. So in this process, it develop a curiosity. Hey, what if podiatric medicine and surgery is for you? Then you develop that interest, then you pursue it. Then if you really feel that this is really the true interest, that becomes your passion of life. And like I said, add the compassion, and then it's your purpose. So it is that transition what I think that how we need to attract the students to our school. Not that they feel it's a picnic in the park, because it's not a picnic. And I think that when we see the students that they fumble or they don't have a smile when things are stressful, they're going to fumble all their life. So it's about picking the right individuals that they know that they're going to a specialty like dental science and oral surgery, perhaps, is a good analogy. And understanding that it's a surgical field, understanding that they have a great income potential, but they need to explore and expand all elements. I have students that they ask me sometimes, well, how do you balance your work and life balance? And I said, it's up to you how much you want to do, how much you want to have. And what exactly is happening, I always say, it's not how much you have in the bank, is the freedom to do whatever you want at all times. So I try to tell them in a different way so they can figure out themselves. But if you want to be on call every 3 weeks, go for it. Sure. I cannot do it. I never did every 3 weeks because it was not for me. But I think that these days, all the schools, they have to really embrace a different level of how to reach. Going to the universities, talking to pre-health advisors, and ask them, hey, give me a chance to talk about my field. And in some way, in those pre-health environments, let's put it, putting the best gift. Because our field is a great present, but it's how you wrap the gift. And I think that still to this day, at the university level, pre-med, they don't really know still what we do.
They do not.
So bad. And I mean, we have done great on hospital privileges, community service, patient care. But when it comes to attract individuals, I think that we're short. So I think that if we can deliver a much better real presentation of what's really the life of a podiatric physician surgeon 2023, it will be great, because I think that you'll be surprised how many students, after they hear my presentation, say, well, I didn't know anything about this. And we have students right now that are pre-health students that they were accepted to medical training, and then they hear some of our interactions and so forth, and now they're looking for podiatric medicine and surgery. So I think that if we continue embracing this way, we're gonna see the future. Not this year, not next year, but at least solidly, we should be able to gather the crops from 3 years.
Yeah, I always say, you're hitting home with the students at the undergraduate institutions when they're flocking to a podiatric surgeon or doctor's office to shadow them, and then the sparks fly. And all I can say is if I have any students in the Chicago area that are contemplating podiatric medicine, they're coming to your office, Edgardo.
Send them over. I can only show them I love what I do.
Yeah.
For me, if I would have to do it again, I would have done it again. If I would have chosen another field, I would not have been so successful, because podiatric medicine offer you so much. And that's what I told my residents. Why limit yourself here when you can do this? Okay. If you do this, you're going to have more for your family to go and offer better to your college, to your children, to go to college, for your vacationing, to pay your student loan sooner. But don't limit yourself here. We show you here. So, but doctor, I don't know everything. No, you don't have to, but we open that field for you. You just need to take it from there. So I think that different times require different educators. I really pray that I can continue this way for some time. And we can continue doing the best we can for our field.
Absolutely. Joe, any comments in conclusion?
No, that was absolutely beautiful.
Thank you so much.
Edgardo, we appreciate you taking time to be on Dean's Chat with us today. This is just a fascinating discussion, and so much of it is around motivation and psychology and mindset, and you illustrate that so beautifully. Edgardo, we're going to send you a Dean's Chat cup that you can drink coffee or your beverage of choice out of. And
that's
again,
awesome. Send that cup right away. It will beat my styrofoam, cup.
That was one of my thoughts. That's good. I like that. And so again, thank you so much. And to all of our listeners out there, if you're on Spotify or Apple Podcasts, please give us a 5-star rating. And of course, if you're watching on YouTube, we'd love it if you'd become a subscriber. So until next week, everyone, thanks again, Edgardo and Joe.
Thank you so much.
Thank you so much. Have a beautiful day.
Cheers, everybody. Bye-bye.